This is Janice Lopez from the International Organization for Migration, and welcome to the Migration Health Research Podcast. This issue of the Migration Health Research Bulletin number 19 features peer-reviewed articles, book chapters, reports, and commentaries focusing on some of IOM's migration health programs such as mental health and psychosocial support, vaccination, tuberculosis screening, and public health emergency management. For this audio podcast episode, we have included two interviews. One with Dalal, Migration Health Division's Global Vaccination Program Coordinator, and Dr. Farah Amin, Migration Health Division's Regional Vaccination Program Coordinator for Africa. Both based in IOM Regional Office in Nairobi, who will talk about the IOM vaccination program for US-bound refugees globally. And one with Sandy Smith, Public Health Officer based in IOM Regional Office in Nairobi, who will discuss migration health governance in Africa. Let's listen to Dr. Farah Amin followed by Dalal. Can you kindly tell us a brief overview of the objective of the study titled An Immunization Program for US-Bound Refugees, Development Challenges and Opportunities 2012 to present?
The main goal of the study was to describe the introduction of vaccination program for US-bound refugees in the year 2012 as part of health assessment activities. It focused on key features of the program development that included the different phases of the program implementation, how the vaccination schedule was developed in close consultation with CDC vaccine subject matter experts, with consideration of Advisory Committee on Immunization recommendations, as well as the national expanded programs on immunization for the different countries, how the vaccine procurement was addressed for the different missions, how the program was structured and the different staff roles and responsibilities, as well as the monitoring and evaluation procedures put in place. It also focused on various implementation challenges encountered and how IOM responded to them to further improve the program implementation. Finally, the lessons learned and the opportunities such a program can provide to benefit similar programs implemented in the migration setting. It is important to note that there was no clear precedent for such a program which will be implemented globally in the migration setting and within a narrow pre-departure period.
Given the objectives that you just outlined, can you tell us briefly about the methodology that you've used for this study?
Different data sources were used to calculate vaccine coverage rates, prevalence rate for hepatitis B infection, vaccine refusal, and adverse events following immunization during the federal fiscal year 2019, which starts from October 2018 to September 2019. Some of these data sources included the CDC electronic disease notification system, which was used to calculate coverage rate based on age eligibility with two major exclusion criteria. One was for measles, where applicants with evidence of immunity were not included, and this was applicable to applicants from Ukraine, where IgG testing was conducted. Number two was for hepatitis B, where all applicants who tested positive for hepatitis B surface antigen were also excluded to calculate the coverage for hepatitis B. Another data source that was used was IOM Mimosa, the Migrant Management Operation System application, which was used to calculate the vaccine refusals as well as prevalence rates for hepatitis B infection among the US-bound refugees. And finally, adverse events following immunization data, which mainly focused on the type of event, the severity, and management, were also reviewed using the reports submitted by the missions implementing the program, which is ideally done within the 48 hours.
What were the key findings from the study that you want to share with us?
As Dr. Farah has highlighted, this program was novel in the fact that it was a global comprehensive immunization program built for refugees that are in the health assessment process and in the resettlement process. And as such, covering so many countries, there were a lot of key findings, but I'd focus on just three. One is the high coverage of measles containing vaccine that we found in 2019, where we're able to achieve a coverage of 94.6 of age-eligible refugee arrivals resettled from 88 countries. And so this high coverage rate of measles shows that the program could be implemented and that refugees could receive the vaccines according to the vaccine schedule. Along with that, we saw that the first dose coverage varied in many of the countries from 51.9% for varicella to 91.8% for polio. So this showed that even beyond the measles-containing vaccine, we were able to achieve pretty high coverage rates for other vaccines based on people's age. Looking at coverage, we saw that Africa had the highest coverage rate among the refugees that participate in this program, followed by Asia. So in regions of the world that many people questioned if we would be able to achieve high coverage rates for this program, we were able to achieve in countries in Africa and Asia. The second thing I'd like to talk about is the cost savings that this program demonstrated, and that this program demonstrated that we could save in relation to immunization costs $225 to $498 per person, reflecting the lowest cost of initiating an immunization schedule overseas. So this just shows doing a vaccine program overseas rather than after resettlement saves a lot of money in areas of ensuring that people receive the necessary vaccines as well as any outbreak-related activities. And the third thing I'd like to highlight is the hepatitis B, and that we were able to test people for hepatitis B. And we found a prevalence of 2.5% in the refugee population that were resettling to the U.S. And this gave us an opportunity to vaccinate negative contacts of those positive refugees and ensure that they could protect themselves from hepatitis B. And it also helped us identify early that refugees had hepatitis B and that they could get the necessary treatment and care post-arrival.
Given these findings that you have just shared, can you tell us what are the key implications of this study for a policy or a program?
I think the key implications for policy is that robust global immunization program that's part of planned migration resettlement is possible, and that countries that are considering including vaccination in an overseas health assessment process, we demonstrated that it is possible and that it can be very successful, and that you can minimize outbreaks among the population, minimize importation of many vaccine preventable diseases into the countries of resettlement, and also help with the post-arrival integration and ensuring that refugees are able to receive a lot of the necessary vaccines prior to arrival, and that post-arrival they only require very few vaccines, and that they can join school, employment, and even adjust their immigration statuses that require vaccination post-arrival with very little burden on the refugees themselves.
Now let's listen to Sunday Smith. What is the main theme or the main key points around the book chapter Migration and Health from the publication Africa Migration Report Challenging the Narrative?
The first ever Africa Migration Report, published in 2020, represents a collaborative effort between the African Union Commission and IOM, and the overall goal of the publication was to advance the African migration agenda, underpinned by the strategic and critical role migration plays in the broader development of the continent. The African Migration Health chapter, led by IOM in collaboration with Africa CDC and the World Health Organization, explores the relationship between migration and health, including resilience and vulnerability throughout the migration cycle, and key considerations and issues related to migration health in Africa. It asserts that migration and health governance should include universal health coverage, migration responsive and inclusive health systems, and control of communicable diseases, all of which are important not only for individual health, but also public health, health security, and sustainable development. However, despite commitments to universal health coverage, which is included in the SDGs, and the right to health for everyone, which is enshrined in international human rights law, as well as key global and continental framework, African migrants often face barriers to accessing health services and information. More specifically, the relationship between migration and health is complex, and health determinants vary throughout the migration process. They can compound health vulnerabilities for individual migrants as well as communities. At the same time, social determinants of health, which are the conditions in which people are born, grow up, live, work, and age, such as the role of gender in society, income, availability of the health system, living and working conditions, and so on, can also support resilience or the ability to recover from shocks and overcome adversity. Migration health is often considered through the lens of health security, where migrants are seen as vectors of disease. And indeed, migration health action in Africa has often focused on communicable disease prevention and control. However, despite common misperceptions and harmful stereotypes, there is no systematic association between migration and infectious diseases in host populations. While the West Africa and subsequent Ebola crises on the continent and now COVID-19 have highlighted the importance of reducing the vulnerability of societies to infectious disease threats, which can easily spread across borders, it is also true that the transmission of such diseases is strongly related to socioeconomic determinants, including poverty. Many migrants across Africa come from communities affected by conflict or economic crisis and undertake long journeys that increase their vulnerability to ill health, while frequent mobility can challenge access to prevention, testing, and treatment services, as well as continuity of care. At the same time, many countries in Africa have struggling health systems and high burdens of disease, which challenge achieving universal health coverage. Migrants thus face barriers to accessing preventative, curative, and other health services in already stretched health systems. Barriers can include lack of affordable health insurance and social protection, as well as issues such as discrimination, stigma, linguistic and cultural barriers, and so forth. The chapter thus addresses the linkages legitimate concerns, ultimately demonstrating that the integration of migration health within routine health systems and migration management is essential if the social determinants of migrant health are to be meaningfully addressed. Health systems that are migrant inclusive and migrant sensitive are critical to achieving universal health coverage, or UHC, and global health security. Investments in migration health with the needs of migrants and communities incorporated into the health system support efforts towards achieving UHC, which is essential for upholding the right to health for all and contributes to social and economic development as well as public health.
Given all these key points that you have just mentioned, are there any recommendations that you would like to highlight that were taken from this book chapter?
The chapter asserts that a shift towards equity inclusiveness for migrants and to leaving no one behind, as member states committed to through the SDGs, is essential for promoting and improving the health of migrants and host communities, as well as overall public health. The chapter addresses both African governments as well as the global health community, arguing that they must consider migration health as a critical component of effective migration management. Migration health must be embedded into health programming goals to ensure that mobility is taken into account. The needs of migrants and communities affected by migration should be incorporated into health service delivery, financing, policy, planning, implementation, and evaluation. Excluding migrants from accessing health services is not only contrary to human rights, but is also poor public health practice. The denial of migrant-sensitive, affordable, and comprehensive health services for migrants poses a risk to public health, with possible negative health outcomes for both migrants and communities. Investing in migration health will help mitigate negative health impacts of migration and ensure sustainable migration gains for Africa. To achieve this, technical capacities for migration health need to be built at national and regional levels to support people-centered, inclusive, and responsive health systems that ensure migrants access quality health services. The implementation framework for World Health Assembly Resolution 61.17 on the health of migrants serves as a guide. Improved research and data will support evidence-informed policy and practice, monitoring of migrant health, as well as efforts to address migration health. Policy and legal frameworks that mainstream migration and health and are aligned with international law across sectors are necessary. Both research and policy can support an enabling environment that addresses xenophobia, exclusion, and harmful myths and stereotypes, which serve to undermine migrant health and thus public health. Partnerships, dialogues, and cooperation across sectors and across borders can support these efforts, as well as health security more broadly.
Thank you very much, Dr. Farah, Warren, and Sunday. And thank you all for listening. Please feel free to share feedback with us. See you on the next podcast.